Thank you very much for the invitation to present in Bangkok HIV. It's an honor to be here. I'm extremely sorry for all the technical issues I had earlier. The line seems to be quite unstable over here, so I'll jump right into it in the interest of time. Right. So the pediatric transition clinic actually had its humble beginnings in a small room. It was basically pioneered by some of the senior ID physicians, adult as well as pediatric ID physicians like Dr. Christopher Lee, Dr. Suresh Kumar, as well as Dr. Kamarul Azhar, who ran it in one room where the patients, the relatives, the doctors, the MTAC pharmacists and ID consultants will be introduced to the patients, and the relatives will actually be introduced to the ID consultants who are basically going to take over their care in the coming years. And this sort of grew, and we've come a very long way now. And currently they've moved into these this very modern building. The entire team is led by Dr. Tahira, and the adult ID team is basically championed by Dr. Leong Chi Loon and his fellow colleagues, as well as infectious disease trainees, where every 2 months we meet up with the families and the adolescent patient, where some of the families might actually be under our follow-up already, like the parents and the adult parents. And the child or the adolescent and the young youth is basically very slowly introduced to the idea that they are going to be finally transitioning into adult ID care later on, right? And this is our hospital. This is my hospital. This is Hospital Sungai Buloh. And this is our clinic, all right? Very colorful clinic, basically held by some core ID counselors, paramedic counselors, very experienced bunch of paramedics, and and our group of doctors. And we generally see adolescent patients in our new patient clinic. And we sort of have a dedicated day, a dedicated team, and two very dedicated ID counselors who hold these patients and their issues for until at least when they turn about 21 years of age, or if they are extremely stable, we hold them for about 2 years before releasing them into the general pool. And this way, there's consistency. The patients get to see the same patient, same doctors and team, and they sort of fall into a rhythm, and they get quite comfortable with the care in Sungai Buloh. So Malaysia was actually involved in particularly Sungai Buloh Hospital was the only adult site that was involved in the STAY study. This is a study that looked at clinical as well as mental and health outcomes, mental, social health outcomes of patients who had adult youths who had transferred from pediatric to adult care. Of note, Malaysia was the only adult clinic that was associated, that took part in this study. A total of 93 of adult youths were enrolled, and they were followed up basically for about a year. All right, and basically demographic data, 60% of them were actually females, and a majority of them were actually perinatally acquired. A closer look at the Sungai Buloh data. It was more of a convenient sampling. So we had about 8 patients only, generally about 17 years of age. All of them were perinatally acquired. They were very stable patients with very good viral load, all right? And they only a small minority actually stayed with their biological parents. Majority of them were either, living on their own, adoptive parents, or actually in an orphanage. About 75% of them are on second line. Although everyone said, they were very comfortable, very prepared, and it was very easy for them to sort of move into adult care from a pediatric clinic. There were some reservations as well, right? Owing to, I suppose, even the society. So when they performed so it was like online questionnaire that they had to timely fill up and there were also there were also physical timed visits, and they had to fill up an online PHQ questionnaire, and all of them actually on an average scored about 7, which indicates about mild depression there. All right. No one actually admitted to be sexually active. All right. And however, and no one had answered the substance abuse questionnaire. All right. And some of the main issues overall in the paper that came out was a trust issue. So it was difficult for the pediatric cohort to sort of go into the adult clinic, because they had probably already formed sort of like a connection with the pediatric providers. And it is quite difficult to actually build that trust again. And many of them did admit to returning back to the pediatric clinic for some advice or some other issues. And if they run into any problem, instead of getting admitted to the adult ward, they would actually get admitted to the pediatric side, right? Depression was something that came up quite a bit. A lot of them had complex social and economic and mental consequences. And stigma was still a significant problem there, in which 67% of them felt that they needed to keep their HIV status a secret, and about 40% of them actually claimed that they did not have any friends or families to turn to, right? So this is Malaysia antiretroviral cohort. This is match database. This is basically a national database, which is mended by each site, each hospital. And this cohort is basically looking at those who are under 23 years old and who have been started antiretroviral treatment, and they are currently under follow-up in Hospital Sungai Buloh. So this is just Hospital Sungai Buloh data. As you can see, as opposed to the stay study, where majority of them were actually perinatally acquired, as the HIV epidemic is at the moment, sexual transmission is sort of increasing, and there is an increase in the amount of homosexual transmission, even among the adolescent cohort. All right. Now, a closer look at these are the adult patients. So a closer look at what we call as loss to follow-up. So this is basically a 1-year data. So 1 year after starting antiretroviral treatment, after 1 year, how many of them have actually lost to follow-up, right? So when we look at this, this is an overall data of Hospital Sungai Buloh, and this is just a look at the youth cohort, right? On an average, about 6 to 7% of patients had defaulted follow-up at 1 year, right? When it comes to the youth cohort, there is slightly lower that was actually seen, patients who are lost to follow-up, but there was a huge sort of jump in 2019. This could be in a largely explained by the pandemic that the whole world experienced, and Hospital Sungai Buloh actually had to scale down on their HIV services and other services, because Sungai Buloh became one of the centers that admit purely COVID patients. So we had to scale down and transfer a lot of other services outside. All right, so that's probably why there was a spike there. But this is more, this is, I suppose, a more holistic data. So this is only adolescent cohort, okay? As you can see, about 50% of patients where everybody was started HART. So whoever was in here are those who had commenced on HART, all right? And then we look at their outcome at 2020. So whoever started HART in 2015, how are they doing in 2020, all right? As you can see, still about 50 to 60% of them are still on first line, all right? I just wanted to bring your attention to loss to follow-up. As you can see, when we look at a similar data in the adult, all right, we could actually come up with an inference saying that adult loss to follow-up is about 7 to 8%, like I showed you in the at 1 year data. And the highest was actually seen in the first 2 years. Subsequently, their loss to follow-up actually drops. Right, so we could make the sort of some quality improvement, saying that the first 2 years or the first year is actually very crucial in the adult patients. If once we get them suppressed on HART, they are actually very, very stable. All right, and we could not lose them from clinical care. But however, a similar inference cannot be made in the adolescent cohort, which is a bit worrying. As you can see, the loss to follow-up percentage is much, much higher in the adolescent follow-up, in the adolescent group. All right. Now, I'm sure I'm appealing, I'm hitting a note with every single parent out there that often wonders, what actually goes on in the adolescent, what actually goes on in the adolescent brain, right? Most of the activity in the teenager's brain, apparently, in a teenager's brain is only about 80% developed, all right? So a lot of things that a lot of things can actually be explained when we just look at the anatomy of the teenager's brain, right? So apparently, most of the activity in the adult brain is actually in the frontal lobe, right? And they are responsible for basically thinking as well as reasoning, whereas the adolescent brain is basically in the central region, right? And which is more of a pleasure reward center. Okay, so I suppose some of the behaviors that we encounter is more physiological, and they're not able to sort of think 2 years ahead, 1 year ahead, and that doesn't scare them. Nothing scares them, not even death scares them, right? And poor adherence, okay, is something which is well documented all around, not just in HIV, but even in asthma patients and post-transplant patients. Adherence rate only ranged about 50 to 60%, right? And some of the factors that affect adherence are basically, it's a laundry list of factors over here, and it's nothing new, stable family situation, having a treatment buddy, simple therapeutic regimes, a physician's empathy, as well as connection with the physician, I suppose ease of access of getting treatment, and teaching them to be more responsible basically has a more positive impact. But look at the negative impact. This is some of the things that we day to day that our adolescents always are exposed to. Mental health issues is increasing, complex medical therapy, side effects, unstable socioeconomic background. So they will have to not just not just think about medicines, but all these factors are pretty real in a real life situation when it comes to an adolescent, right? So through our experience, we don't expect to be a professional or a expert in dealing with adolescents, but through our experiences, I would like to share some cases that we have in our cohort of patients that taught us some important lessons in how to deal with an adolescent patient. So, 16-year-old boy, only the parents with a circle of confidentiality, we call it COC, right? He was adopted as a baby. His 2 other siblings after him, diagnosed with HIV positive at 2 years of age when presented with PCP. Started on Combivir and efavirenz. Viral load was always very high. He was then switched on to second-line treatment. And some of the issues in the pediatric clinic was poor compliance, failure to thrive, failing parents' marriage, a quiet kid, he always smiles a lot in the clinic, never talks a lot. And he came over to our adolescent clinic with this kind of viral load and a low CD4 count. All right. In the adult clinic at 18 years of age, resistant testing showed that he was resistant to all the NNRTI, lo and behold. He was also having high-level resistance to Kaletra, Sequinavir, Atazanavir, and Indinavir, and some intermediate resistance to some of the NRTIs. Right. Several meetings with adopted family. All right. And mom decided that she's going to take over. She's going to dots him, she's going to sort of watch over everything, and the boy can't, and he was completely under her control. So she was on more of a salvage therapy kind of a regime. And some of the strategies which were discussed and used was a very strict timetable, direct dots, he takes it right in front of her, SMS reminder, homeschool, home kind of a life. All right. The boy literally had no life. All right. 4 months later, lo and behold, obviously he was viral load suppressed, sustained for 1.5 years. Now, at 21 years of age, his CD4 count is 310, viral load is unsuppressed again. So it's been 2 years since he was viral load suppressed. He had finished school, he had gone on, and he has started working and basically studying part-time. So basically, he started living his life, right? So this was some of the, with the patient's permission, this was some of the conversations that we basically had when we saw this CD4 count viral load 34,000 and the parent sitting at the back and just shaking her head, very, very disappointed with the boy. So we decided, the young man. So we decided we're going to separate them. So after a few follow-ups, these were some of the statements that he made. You know, it'd be nice for me to come at my own time so that I don't have to miss work. That way we can be able to balance my life. You know, school doesn't suffer, you know, clinic appointments doesn't suffer. Doctors make me wait for so long and we tend to get really bored. So this is a boy, this is a young man who has been viral load suppressed. So he actually has been released back into the other cohort, you know, they're into proper clinic appointments, right? Instead of adolescent clinic appointments. So, so he's saying that sometimes a few other statements also sort of gave us some realization. So he basically said, whenever he quarrels with his adoptive mother, sometimes she says things that hurts him, right? So she says things like, she's not her biological mother, biological parents are dead. So she says, I'm not the one who gave this to you, so you don't hurt me back by not taking your medicines, right? And of course, stigma is always there. So one time he said he came to fetch his medicines and saw his neighbor was there, right? And she knows that he's HIV positive, or he assumes that she knows that he's HIV positive, and he feels very stigmatized by it. Right? So some of the issues that were discussed and we realized as well is, come on, you know, the parents did not prepare him basically for adulthood, right? Could not manage the timing himself. Once he was released into the outside world, he had very poor understanding, got lost in the excitement of adulthood and living alone, right? And some of the social issues that basically came up is he started becoming very interested in the opposite sex. He has no way of documenting or talking about it, you know, because his mother was quite against all this, and the medication was actually feeling him very abnormal, and he had many awkward moments with his friends, right? So some of the yes, we struggled to get him back on track, but eventually did. But some of the lessons that we learned in this case was it's important for us to teach independence to the young adult, even though it may be painful for the parents. So helicopter parenting is fine at one point, but they have to be taught some kind of independence and take responsibility for their own medicines, right? And we can, and at stages, I suppose, you know, it's important to identify an early treatment buddy, right, that they can actually relate to and arrange for drug collections or you know, special services that pharmacy can actually. So in our hospital, we actually have what we call as they can actually collect medicines through several ways. They can be posted to their house, you know, or their workplace. It can actually be collected at a hospital near them, or they can come in after office hours to actually take the drugs. So these are some of the changes that we made along the way as well. All right. So this is the second case that I want to share with you. So it's a 15-year-old. She's perinatally infected. She lives with her grandparents, and no one else knows about her status. All right. So parents have passed away. There are uncles and aunties, but generally she lives with her grandparents. All right. And she had a very traumatic sort of experience as a child, and frequent hospitalization, multiple medication, and ART-wise, she was finally suppressed on a Comivec Calitra for a very short period of time, and subsequently became never suppressed again, all right? And came to adolescent clinic in Sungai Buloh, CHSP Sungai Buloh, with a CD4 count of 219 and a high viral load. All treatment was stopped for 3 months, okay, prior to coming in, all right? So first time, it's a really, really timid child who even took time to sort of come in and sit down in front of us. Was 1 hour consultation, and all we did, or we got her to do, is actually to play tic-tac-toe. That's the only thing happened. 2-3 consultations later, we saw her through, she often talks about all this people. So Bapak Saudara means uncle. Tuti is her cousin. She talks about her grandpa. She likes her grandpa a lot. She talks about her grandpa. Obviously, this is something that we brought up, HIV and medicines, and of course, she admits to really wanting some friends, right? She talks about her friends. So we did sort of like this pizza chart, and asked her to give us a smiley face or a sad face or an angry face, and she didn't do it the first time around, but at the end of probably the second or third consultation, she gave us some important realization regarding what she actually feels when it comes to certain aspects of her life, of her, I suppose, young life. Right. And at the beginning of the first consult, we do this quite often. At the beginning of the first consultation, especially in youths that are not doing well, we give them a notebook and we tell them every day, write down things that make you happy and make you sad. And the notebook was never scribbled at all. But suddenly at the fifth consultation, she wrote this. All right. Obviously, it's typed out here, but this is some of the gist of things that she wrote. So she basically wrote, "Kenapa saya kena makan ubat?" Basically means, why do I have to take medicines? You know, drugs are making me sick. No one cares about me, and I don't like going to the doctors as they always scold me. You know, so they say always tease me, always scold me, tell me that, you know, I'm not taking my medicines and I'm making myself sick, and I'm also burdening my aunties and my grandparents, right? Now, this is a paper that basically talked about adherence to treatments and how to improve adherence to treatments. As you can see, a non-judgmental, strong relationship with a teenager is extremely important foundation that we need to lay, all right, before we can actually get even 10%, win 10% of their trust. Even 10% is probably a big number. And interviewing, giving them some sort of autonomy is actually very important. So interviewing them by their own, as if they want it, you know, interviewing them by their own. So we always ask them, you know, are you comfortable talking in front of, this will happen even before they actually come in. Be comfortable happen. So what we will do, if they are together with a relative, we will ask permission to talk to the teenager first. You know, and many of them actually want to talk alone after several follow-ups, right? And I've always wondered, maybe it's not always them who need to change, but we basically need to change. So the appearance of our clinic room is often like this, you know, which is not so inviting compared to such a beautiful setup like this. Obviously, not everybody has this, neither do we. But our body language is actually extremely important as well. So a very empathetic sort of body language, where we're not always plastered to the pages of our notes and computers. I suppose is not just limited to an adolescent cohort, but will also apply to other age groups as well, you know. And of course, it's important for us to not miss the elephant in the room. So timing of medicines, you know, it has to be appropriate. Logistics, do they have to travel 20, 30 kilometers to just pick up the drug? Some of the side effects that we can't live with, you know, it's like living on an Atkins diet the whole time. And of course, are we giving the wrong drug? You know, these are some of the things that we regularly look at as well. So some of the issues we identified was Kara was burning out and often gave into the child's mood. So the child doesn't want thick medicines, they just leave her alone because she had such a hard time anyway. You know, there was no disclosure was done, as the grandparents forbid it. You know, they didn't want anybody else to know. They didn't want anybody to ridicule. They loved the child too much that they often gave in to these feelings. You know, child was very depressed, but she probably didn't know about it. You know, she was constantly just spending time with the grandparents, and she didn't have anyone of her own age group. And some of the side effects were explored in a non-critical way. So we basically said things like, you know, rephrasing our way we ask for side effects is also, I suppose, very important. So we do say that a lot of people actually have vomiting and diarrhea and problems taking medicines. How about you? You know, and we managed to get something out of her treatments. So what we did, treatment was simplified, full disclosure done. Uncle stepped in and just took her over, all right? And the medications were switched to a daily dosing. And so what she was, it was easier for her because she had very minimal side effects on these drugs, and she could actually go to hospital, go to school and come back. There was an alternate carer, so the uncle actually had his own family, and there were some kids who were with the same age group as her, and she was very happy. She started going to school, and 6 months later, viral load was well suppressed. All right, and until today, she's doing well. All right, I was quite happy to see her every time. So lessons that we learned this time: sometimes being too compassionate and lenient may not be in the best interest of the patient, right? So expanding the circle of confidentiality to the uncle who showed interest in the care. So we realized that, sometimes grandparents are really old, and sometimes there has been unfortunate incidents when they suddenly pass away, and this child who had been solely under their care is left without any carer whatsoever. And she herself probably doesn't really understand or the complexity of her situation and her disease. And the other people find out, like, shockingly, and may not actually accept her or may not appeal to her problems, right? So expanding the circle of confidentiality to other well-deserving family members is something that we probably need to introduce on an early basis itself, and allowed her to indulge in an interest in it, right? And we realize this is a growing youth. She's got her own likes and dislikes, and she's got own hobbies and interests. And it's extremely important to make sure that she has her own sort of peers that she mixes with, so that we indulge. So she's given an opportunity to indulge in her interests and not make medication the center of everything, sort of tied in. The last case I wanted to talk about, it's about our happy home, our trip to an orphanage. So basically the scenario is we had 4 kids who were coming from one home, and they were all not viral. They were not virally suppressed, so they were all different in their own behavior. We had the cool one, we had the silent one who would say nothing and just nod to us. We had the hopeless romantic who kept getting into relationships and getting his heart broken, and never shying away from the next partner. And of course, we had a youth with learning disability, and the only thing makes him happy is basically he just loves to eat, and there was a pleasure gain reward system that was going there. So we wanted him to eat his medicine. He's supposed to give him his food. Right. And some of the issues that we picked up during the site visit is everybody oversleeps. They don't have a specific time interval where they're taking medicines, although they were all living under the same roof. They were all retroviral kids, but they were taking medicines haphazardly, somewhere at 10 o'clock, somewhere at 6 o'clock, somewhere in the afternoon. It was quite all over the place, right? They were very cliquish, okay? They had diverse personalities, some were very good in studies, some were not, some were interested in something else, and they were very cliquish in their own. A lot of them were battling with some kind of side effects, Some of them actually had work commitments, and of course, I brought up the kid with the learning disability and some health, mental issues. So some of the interventions that we did, we brought them out for a meal. And we realized that they needed some more group activities. They couldn't be so cliquish. They were all in this together. They had to be more involved with each other. And they were all, majority of them did get along, but they just didn't have activities that they could do together, And the caregiver at home decided that he will be the dog's agent. And we also realized that we needed to get them prepare them for adult life. And we introduced that they probably need some vocational school training or to learn new skills to basically prepare them for future. And one of the interventions that really worked was basically we had a specified time for them to actually take medicines. And that was a group activity that they all did together. and some of the lessons that we learned. Of course, we couldn't save everybody in that case that I shared. It was important for us to work with whatever we have. It takes time, right, to actually invest to gain their trust. So some degree of non-compliance is something that we have to learn to be comfortable with, right? And it's important to prepare them for future life. So we encourage all of our adolescents to actually take some form of life skills or vocational training or further studies in those who are doing well, so that they are well prepared for the future. All right. And of course, this was a nice paper that looked at some of the interventions that improve antiretroviral therapy. As you can see, very often nowadays, multimedia-driven counseling like videos and contents to remind patients to take their medicines works better. And of course, a weekly SMS from dedicated nursing from a dedicated personnel is also something that sort of improved adherence as well. This was also quoted in some of the WHO guidelines, and a community healthcare sort of support group was very helpful in some of them in increasing adherence as well. But this kind of adherence, which is a physical meeting, monthly meeting with pharmacists, and more of physical-based visits and task shifting, even if it is task shifting, but it's physical visits, had not a very good impact, sort of did not have any statistical impact in terms of adherence and virological suppression. But definitely something like this, a mobile clinic, may appeal in some situations, right? And some of the limitations that we had is, of course, during the we actually lack. One of the biggest limitation, I would say, we actually lack community support. So as much as everyone wants to help, but we don't have sort of like a community support group just for the adolescents. Internet support groups are there, but seem to need a very dynamic personality. More often than not, our Malaysian kids sort of feel left out in these, And I suppose in the time of social media, telehealth medicine is something which may definitely improve in cutting down physical visits and improving adherence, and of course, this thing of task shifting, right? Sometimes an adolescent who's doing very well can also play a role of a counselor and after formalities are settled, possibly make a greater impact in improving adherence in this adolescent cohort, all right? And thanks or no thanks to the pandemic, we were forced to sort of think of more alternate methods to scale out in order to improve adherence as a whole. And Sungai Buloh actually has a teleclinic session 2 to 3 times a week where we actually schedule patients for follow-up and have a set of questionnaire that we go along with them. And this cuts down their clinic visits significantly. And it's a hit among some of the adult patients and adolescent patients as well. And of course, we have every afternoon, we have a WhatsApp service that we provide for patients, where they will WhatsApp or their complaints and need to reschedule appointments or some questions that they have. And often those questions can be anything. And we actually have one of our counselors sitting from 2 to 5 in the afternoon every day to attend to these WhatsApp services that basically WhatsApp questions that come out. All right. So in summary, I would like to end by saying it's important for us not to be too judgmental. We need to accept some degree of collateral damage and non-compliance. Simplified regime works the best. Don't be disheartened. We realized, do not be disheartened because the rapport is not instantaneous, but it's also important for us to be a little bit firm and not forget our aims. So peer supports and community activities will be the future when it comes to improving adherence, not just in the adolescent cohort, but also in the adult cohort. Sometimes treatment interruptions may work in the short term, although this is not recommended in the guidelines, but it's important to sort of prepare them for adulthood, and they all need hope and life skills to sustain themselves. And sometimes we need to think out of the box a little bit to improve adherence and trust. With us, I thank you. Thank you very much.